Hey everybody, it's Rishi Agrawal. In this video, I want to show you a classic chest x-ray case. This is a 24-year-old patient who presented to the ER because of facial swelling. And as you can see, there's this large mediastinal mass. We can see the aortic arch very well, and it's normal in size. And importantly, there was no trauma or chest pain, so this isn't an acute aortic syndrome. On the lateral view, you can see that there's this mass in the anterior mediastinum here. So remember, our differential for an anterior mediastinal mass is the 4 T's: thyroid lesions, thymic lesions, teratoma, and terrible lymphoma. Now, because this patient is only 24 years old, my first choice would be lymphoma, and specifically Hodgkin's lymphoma, which is what this turned out to be. Remember that one of the big demographic differences between Hodgkin's lymphoma and non-Hodgkin's lymphoma is that Hodgkin's lymphoma has this bimodal age distribution, where you have this big peak in patients between 20 to 24, and then it tapers down, and then it goes back up again as you get above age 55. Now, non-Hodgkin's lymphoma, NHL, is much more common than Hodgkin's lymphoma. If we take all lymphoma patients, non-Hodgkin's lymphoma accounts for around 90% of those patients. But when we're talking about intrathoracic disease, 85% of patients with Hodgkin's lymphoma present with intrathoracic disease compared to only 45% of patients with non-Hodgkin's lymphoma. We also know that non-Hodgkin's lymphoma is much more common with increasing age. So that's why I could say that that patient who was only 24 was more likely to have Hodgkin's lymphoma than non-Hodgkin's lymphoma. While we're on the topic of incidence, you should know that thymic tumors are much less common than lymphoma, and these have a peak incidence of around 70 to 74 years of age. Teratomas are even more rare than thymic tumors. On CT, the mass is usually pretty homogeneous, but sometimes you can have cystic or necrotic areas. You can see that this mass not only involves the anterior mediastinum, but it also involves the paratracheal region. The mass can invade adjacent structures like the pericardium and chest wall. It can compress vessels like the SVC, causing SVC syndrome, which was what was going on in this patient. And it can involve the pleura, so you can have pleural effusions. Remember that Hodgkin's spreads contiguously to adjacent lymph nodes. So if you have a large mass in the anterior mediastinum, you're going to get lymph nodes next in the paratracheal region, then hyla, then internal mammary region, and then pericardiophrenetic region. You're not going to have big skip areas like a lesion in the mediastinum and then lymph nodes in the inguinal region. You can see it in the lungs, and patients can present with lung nodules, masses, and consolidation. And in patients who do have lung involvement, you're almost always going to see mediastinal and hilar involvement as well. Let me show you a few more companion cases. This patient was 25 at presentation, and you can see that there's abnormal contour of the left mediastinum. This patient, we lose the contour of the aortic arch, and we have a hilum overlay sign indicating that this does not involve the hilum. On the lateral view, you can see that there's fullness in the retrosternal clear space, indicating that this is an anterior mediastinal lesion. We also have opacity in the retrotracheal clear space, indicating that it's extending posteriorly. This was also Hodgkin's lymphoma. Here's another patient with Hodgkin's lymphoma whose chest x-ray isn't as obvious as the one I just showed you, but you could still see it's clearly abnormal. There's widening of the superior mediastinum here, and there's an abnormal bulge along the left heart border, which corresponds with this opacity here, and there's just too much here in the anterior mediastinum. On CT, you could see that this patient has that classic contiguous distribution of lymph nodes, with lymph nodes in the left axilla, lymph nodes in the left supraclavicular region, lymph nodes in the anterior mediastinum and right paratracheal region, and this bulge here on the chest x-ray corresponds to a conglomeration of lymph nodes in the inferior aspect of the anterior mediastinum. And you can see that some of these areas have cystic or necrotic appearance. Here's a patient who was a little bit older. This patient was 42 years old, and again, you can see that this patient has a mass in their anterior mediastinum, and on the left border, it's kind of fuzzy, so I would be worried about direct extension into the lung in this patient. And on the lateral view, you could see that it's an anterior mediastinal structure here. So you can see that the imaging appearance is very similar to the ones I just showed you, but this patient was a little bit older at 42, so they're more likely to have non-Hodgkin's lymphoma compared to Hodgkin's. And finally, here's a patient who had Hodgkin's lymphoma in their 20s, and now they're in their 50s. And you can see on their chest x-ray that there's calcified lymph nodes here in the right paratracheal region. It's actually easier to see on the lateral view. We have a conglomeration of calcified lymph nodes in the anterior mediastinum and up by the trachea. And here's what it looks like on CT. Large calcified lymph nodes in the right paratracheal region and in the anterior mediastinum. And if we go to lung windows, you can see there's a little bit of radiation fibrosis right next to the mediastinum. So if you come across a chest x-ray that looks like this, and the patient doesn't have any history of trauma or chest pain, I want you to think of lymphoma, and in particular Hodgkin's lymphoma, if the patient is in their 20s. The next step after the chest x-ray is to do a chest CT with contrast. And then the best way to assess the extent of disease is to do a PET CT. There's many different subtypes of Hodgkin's lymphoma, and fortunately the most common subtype, nodular sclerosing, has a good prognosis. Okay, that's it for this video. Check the description below for some of my chest radiology book recommendations based on your level of training. And if you have any questions, please let me know in the comments. Thanks.